in this conversation, poor you. And those that are not on the screen, welcome to this IGIB for January, the beginning of the year. I think it's too late to wish everybody a Happy New Year, but I'll do it anyway just to play safe. Happy New Year. Hope it's a prosperous one for all of you. The next thing is to ask for the apologies. Elaine, do you give us those, or?
Sorry, I've got them, John. The only apology I have is John Traynor, and Michelle McCargo is appearing in his absence.
Okay, yes, I see Michelle was on my screen being very very quiet and thoughtful. Welcome.
Good morning. I didn't really know what I should say, John. I had lots to say about what the conversation was like, but I thought I should probably be in my best behaviour, given it's my first meeting.
Well, I think that's wise. It's always a good indication of a wise person when they keep stoom in their first meeting. But welcome to you. I ask all the members and everybody that's in the meeting, if you any interest to declare, that is to say anything you think that might be associated with stuff on the agenda that you should speak up about. Is there any interest to declare? I don't see any hands up, so thank you for that too. And I come on to the minute of the previous meeting, which I shall do. Here. Let me go through this. I'll go through it page by page. Page 1. Page 2. Page 3. Page 4. Page 5. Page 6. Page 7. Page 8. Page 9. Page 10. Page 11. And page 12. In the absence of anyone putting their hands up, do I take that as a true record in terms of accuracy and content of our meeting, our last meeting? Thank you. We come to the rolling action log. Christine, is there anything we should note here?
So no actions that were due today that are not on the agenda, John.
Okay.
So we've got the membership update just coming up from Mark. That's on. So nothing else to update on.
Okay, and no one else have anything to say or comment? Okay. Mark, do you want to take the next item, which is the membership update, please?
Thanks, John. There's very little I would add to the terms of the report. It just simply asks to note the appointments of note and confirm, sorry, the appointments of Mags Kerr, Dr. Shilpa Prazed and Dr. Stuart Sutton. Thanks.
Okay. Is Dr. Shilpa in the meeting?
Yes.
Yeah, she's there, John.
Yeah.
If you say hello, you'll come up on the screen.
Yeah. Good morning. I'm Shilpa Prasad. I'm a clinical director at Adult Mental Health Services in Renfrewshire.
Okay, I see you there, and I see Stuart as well. Welcome, Stuart.
Thank you.
Okay. So we now welcome Caroline Sinclair. Caroline, there you are again. I keep seeing you. You were on the Glasgow IGIB as well. Welcome to Renfrewshire. And where are there's others that are there to support you, Karen and
John. Yes, we've got Karen Lamb, Head of Specialist Children's Services here with us, and we've also got Julie Metcalf, Clinical Director, who's joining Caroline and joining us today.
hello, Julie, again.
Hello.
You're on my screen. You were on my screen on Wednesday at the IGIB, and Karen too. I think she was on.
Good morning.
So, Christine, are you going to introduce this and take it away, or have you already done that?
No, John, I'm just going to do a very brief introduction, more of a reminder that we have talked before about specialist children's services and the kind of direction of travel that potentially children's services would be getting hosted in one area across GGC. So that decision has been made. So you've got a paper that gives some of the detail about the single service structure for specialist children's services that will now be hosted centrally for the board area by East Dun, HSCP, and Caroline and Julie and Karen are here to just take us through what that will mean for our services within Renfrewshire. So that's all I wanted to say in way of introduction, John.
Okay, is Caroline, are you going to take it away?
Yes, thank you, Chair. Thank you, Christine, and thanks everybody for the time today and the opportunity to just come and brief you on the plans. So the purpose of the report that you have in your pack of papers for today is to update you on the steps that are being taken, as Christine has outlined, towards implementing a single service structure for specialist children's services for the Greater Glasgow and Clyde Health Board, and that includes within it CAM services and community paediatric services that are currently delivered through your own integration joint board in your own local area. It's moving towards a hosted services model, and Eastern Bartonshire have been asked to take that hosting lead role. So it's a noting paper for members at this stage, just to brief that in to make sure you're sighted on the direction of travel. In your next board cycle, there will, however, be a more comprehensive report that sets out the details of what's transferring within that arrangement, and at that point in time, that'll be for your consideration and hopefully approval. So within the health board, I think it's important to understand that there's currently a very scattered arrangement for the governance, management and accountability for the specialist children's services, and one of the reasons that the decision was made by the board some time ago to bring these together into a single structure is the fact that between the sort of tier 2, tier 3, tier 4 services, they are managed in different places, reporting in different places, and actually overall, in terms of the health board's total service provision, they're not actually very large services, and that it's created a very complex multiple reporting arrangement with some challenges around how flexibly resources can be used in response to changing pressures, and how consistently service improvements and developments can be implemented across the whole system. So it was taken as a management action decision by the health board. I think it might actually be originally back in 2020 or 2021, at sometime around 18 months ago, that this would be brought together into a single structure, and that there would be benefits and clarity and some reduced complication around governance in doing that. And that's a decision that the Scottish Government are keen to see progressed, and one that myself, Karen and Julie report monthly on to the Scottish Government Mental Health Directorate on progress around that. So the principles that underpin the decision and the intention behind it is that really rests on promoting flexibility, creating resilience in what is actually a very strongly growing area of service demand. You'll have seen yourself there's a lot of complexity. We've never seen higher numbers of referrals into these services, so it's really important that they are facing forward about how they will be resilient for the future. But in putting that structure in place, it's recognised that it does change things in individual health and social care partnerships, You've had the services within your partnership for some time, and over that period of time, there have been lots of really great developments within the services about how connected they are into other key important players within the wider system of services for children, young people and families. So the relationships that have been built with education services, the relationships that have been built within social work, social care, health services, and all the work that's been going on at a tier 1 and 2 level led through your own services to implement more of that children's health and wellbeing agenda and make sure that there are earlier stage interventions available for these children and young people to access. So in recognising that in any change that joins things up in one direction, it's got the potential to disconnect them in another direction. So the integration implementation is underpinned by 3 principles, which is that services will continue to be delivered locally and by your existing teams, so that there is no intention to change the specifics of the staff delivering the services. The intent is that those people who are receiving the services would not actually notice that this is different, same staff in the same teams delivering the services. They remain located where you have them located, so they remain embedded within local practice teams, and that the services will continue to work closely and in partnership with health and social care partnership colleagues who deliver other services, and with education colleagues and others that operate, and primary care colleagues, for example, that operate within the local area, and your third sector colleagues that have been building up these tier 1 and tier 2 intervention. So the report at this stage gives you sight of the direction of travel, outlines the intention to make that a hosted service. That's a fairly common service model across NHSGGC for delivery of pan-GGC services that are delegated to partnerships. And so it gives you sight of the intention, and we're happy to take any questions. So I'll leave it there if I may, Chair, and I'll do the easy questions and Karen and Julie will do the difficult ones.
That's taken for granted, Caroline. Thank you very much for your report. I see Ian's Ian McMillan, you're first up.
I'd be glad to know. Mine is quite an easy question. I suppose it's a comment first, really. You know, when I hear of any services be centralised, I start to shudder. As a local councillor, I certainly believe that services should be as local as possible. We've seen other health services being centralised and people having to get 2 and 3 buses to get to places, and it's been a bit of a nightmare for people. So I suppose at 3.4 it gives me some kind of reassurance that on the ground people who use these services are not going to notice anything. So you know, that does provide me with some sort of comfort. So I've got a fairly straightforward question. It says Eastern Barton, but where are they actually going to be based in? I know it's not the biggest of places, Eastern Barton, but where is it going to be based within Eastern Barton? Thank you.
Yeah, thanks. We're not going to move any of the staff who deliver the frontline services at all. So there will be no services relocating to Eastern Bartonshire. Karen, do you want to say a bit about where the services are currently based?
Yes, certainly in Renfrewshire, your services are delivered through the Arran through. Each HSCP has different locations. Most of them are integrated locations where specialist children's services are sited alongside social care colleagues and universal children's services. The senior management team, Julie and myself, are based in Templeton, so that will maintain as well. So there are no moves for anybody planned across the whole board.
Okay, Ian.
So that there is actually, although it keeps mentioning Eastern Bartonshire in the report, there's not actually nothing actually moving there. It's just going to be kind of managed from there. So there's no staff at all, or is that going to feature in the next report? Because I noticed there's going to be another report to follow. So I'm not entirely sure. But so there's nothing moving,
no.
Nothing at all. And I'm not talking about frontline services. I'm talking about maybe management or overseeing it. Nothing's moving to Eastern Barton.
No, that's not in our plans. As I say, the SCS management headquarters, if you want, is at Templeton. We have no no services that we plan to management or frontline that we plan to move anywhere at this point, unless something comes up with an issue with one of the buildings somewhere and we need to manage that as we move forward, but certainly not at this stage and not even on the horizon.
Okay, Jackie, did you want to come in?
Councillor McMillan, the service manager who manages the service along with all the team leaders are based within Renfrew, so they are very visible to the service, and the service will remain local, and we've had the commitment from that, so it will continue to be delivered from Renfrew and Renfrew, which is the old Renfrew Health Centre, and that will maintain.
Okay, thanks for that, Jackie. Can I go to Margaret Kerr?
Thanks, John. Thanks for the report, guys. Can I wind back a little bit, because the report refers to, and Caroline, you mentioned that the Health Board made the decision and it was some time ago. I guess I just want to understand that a bit better, because this was news to me in the paper. So I'm just would like to understand how that decision was made and where it was made. John Matthews, I don't know if you recall, I'm not trying to test your memory, but how was that decision come to? Where was it approved, if it required approval, and what was the basis of that? And the basis question forms the next part of my question, which is, what's the driver for this change? Does it have an impact on the overall budget that the services are delivered within, or is there evidence of improved outcomes? Because I'm guessing it's one or both, or a combination of both.
Margaret, there was quite a discussion about this at the Glasgow IGIB about whether the board had its process had been as clear as it might have been. But I'll let Carolyn speak to that. She was there, so she knows the.
Yes, thank you, Chair. Yes, it's an interesting question, and I'm sorry I don't personally have the history to it, because I picked this up relatively recently following the retirement of the person who had been leading on specialist children's services. So what I've undertaken to do is to go back to the Health Board colleagues and just test that out and make sure that governance question is properly addressed and considered. But the position that I was advised of by the board's governance lead that it fell within the remit of things that can be undertaken as a management decision by officers within the Health Board, because it's not required to be a delegated service to health and social care partnerships. It's not part of those that must be delegated in terms of the Public Bodies Joint Working Scotland Act, and therefore it falls entirely to the Health Board to decide how that is managed, where that's managed, and how that is implemented, where it is indeed, if they wish to delegate that to partnerships. But I have undertaken just to test that out and make sure that everybody's content with that governance process. In terms of the rationale about if I may, Chair, just moving on to the rationale, I would maybe invite Julie Metcalf, who's the Clinical Director for CAMHS, to talk a little about that. But it broadly, it's not about attempting to reduce the budget. The budgets will remain as they are. They will transition to be managed through Eastern Bartonshire instead of through the 5 separate partnerships as they currently are. But there is no reduction target associated with that. And the intent is to promote flexibility and stability in what actually are quite small services in a growing context of service demand and significant upturn in demand. And there are some challenges in managing that in such a disparate way at present that the single structure aims to promote. But if it's okay, Chair, I might ask the Clinical Director to provide a bit of comment.
By all means, Julie.
Thank you. Yes, as Caroline said, we're a complex structure anyway. We have many interfaces, I suppose, with yourselves across the HSCP system, with Women and Children's and the Acute Hospital for Children, with adult mental health, often in terms of some of the things that we're taking forward, with primary care and community services. All of that is part of how we're working. We have regional services, national services and local services, as well as board-wide services. And I think our medics, just to be clear, our medics are managed by me centrally, anyway. So all of the psychiatrists within your service, I manage, and one of the advantages of that in terms of stretch and workforce, lack of workforce availability, I guess is the best way to put it, is that we've been able to flex that as far as possible. Jackie knows that that's been challenging in Renfrewshire, just to provide some support into services where there's a very significant gap. We haven't been able to do that with our other professional groups because they're managed through the HSCP systems in the same way. So we negotiate as best we can, but we're negotiating through multiple systems to do some of that. We've got a central governance system, central quality assurance system, where all of your service managers, professional lead staff that are part of the system will come to and will join up as much as possible around quality assurance. But I think it's that flexibility that Caroline talked about in terms of, I suppose, being able to use our resources in the best way to meet need without taking resource away from areas that need it, but doing that in a flexible way to try to meet the demands that we've got at the moment. And our locality teams work with our central teams to deliver care. And just to, if it's, I hope it is reassuring for you to know, I think that we work very well together from a central point of view, from my point of view, with Jackie and with your local service. I hope that people here feel that there's a join up there and that we've been able to do that very well in partnership. And we don't want to change that. We want that to continue at clinical level and at ground level and at patient need level.
Thanks, Julie. Christine, I see that you've joined. Did you want to clarify on this?
Yeah, I just wanted to say that on the ground, there will not be any changes in terms of the staff who are currently known within Renfrewshire, known to our families, and also who have got those relationships across GGC, the council and third sector. So that bit won't change. The bit for us that will change is that, as Julie said, some of our staff in Renfrewshire are already managed centrally, but some other staff are managed by Jackie, our head of service, and then obviously by me. So that's the bit that will change. But the services on the ground, the relationships that are already well established across Renfrewshire that we're proud of, will not change because it's going to be the same staff. So it was just to clarify that, John.
Okay, thank you, Christine. Jennifer, you've been waiting patiently, and John, so is
John. Can I sorry, before you move on, John, can I just thank Caroline? I think it's really important that we clarify that point around the basis for the decision and the board decision. Notwithstanding all the comments about the service delivery, the outcomes in terms of using resources all make sense, but I think it's really important in terms of this being a change to delegated services, and that we understand both from the board and the IGB where the responsibility and the accountability lies. Having that clarified is really important. Thank you.
Well, we had a big discussion about that, Margaret, and I did ask the question, if the process had been correct or to our satisfaction, would we have agreed to note this anyway? And the answer to that was yes, but we still have an issue about the process. And Caroline has said that she is going to take that back to colleagues to try to clarify whether it was just the sheer distance of being back in 2020 or what that's confusing us. But I don't remember sitting in a board agreeing to this, but we need to clarify that just for our own governance purposes, and we will do that through Caroline, correct? Caroline, you will do that?
Thank you.
Yes, Chair. Thank you.
Yes. Okay, Jennifer, and you're next. You've been very patient.
Thanks, John. It's just to thank Caroline and Julie. I think you've laid out really quite clearly the benefits behind the single hosting arrangements. And I know there's anxiety whenever we talk about, merging something to a single structure, but I do take comfort in the fact that services are going to be continued to be delivered locally and everything that Christine just said. So with that in mind, as I say, I'm happy to see the report and approve it or note it. And I look forward to the update coming back in March to see how we're going on with the transition.
Okay, thanks, Jennifer. Anne Cameron Burns.
Thanks, Chair. With the absence of our staff side trade union colleagues here, I thought it would be prudent for me to mention that from the NHS side, yes, I don't remember it coming to the board, but I wasn't the employee director then when it was coming, but I definitely know as the employee director now that I have asked questions on the input from our staff and staff side representation to their HR manager, Tom Quinn, and there was failure to engage with the staff at the beginning regarding this process. So they talked about partnership and partnership working within your HSCPs, but you forgot to have the partnership working from the trade unions on this. So I believe that I'm getting some feedback from Tom later and my other colleagues within the HSCP's staff side to take this forward and see why they weren't engagement with us or full engagements with us under our staff governance. So just because I know that Annie Hare's not on, and I don't think anybody from the council side would have known about that. So I thought it was important that you were given that information, that the trade union and staff side were concerned that there were really no partnership working with the trade union. Partnership might have been partnership working with everybody else, but they failed to do it with staff and colleagues. I have the reassurance that there will be no positions lost, and everybody that's working in the area will stay working in the same area. And actually there would be an input of another senior manager at one point in this process to oversee the management of the staff. So I believe they're actually going to be another member of staff put in somewhere in the workforce. So that's my understanding at the moment regarding this, Chair.
Okay, I think Anne's point is for noting and for an awareness, putting up a flag. Have you anything to say, Carolyn?
Thanks, Chair. No, I would only add that there is a working group with staff side engagement included within that membership to oversee the programme of change, and the first meeting of that group is at the end of this month, and I believe invitations are out for that meeting along with papers. So it may be tied to the governance question about in what forum was what engaged with and when originally, that we may have lost a little bit of connection there, but we've certainly aimed to rectify that once Anne brought that to our attention.
Okay, thank you. Fiona Ailey Nicholson.
Thank you. It was really just, I suppose, to reinforce what Margaret was asking for, Margaret Kerr, just in terms, I wasn't around, obviously, in terms of the IGIB in 2020 or whenever this decision was made to change the process that was already in place for delegated functions within the board. And I would be keen to understand how a decision like that could have been made and the process that was followed when we've got so many who probably were about here who seem to have very little or no recollection of that process. So I look forward to Caroline coming back with the explanation for that. Thanks.
Thanks, Fiona. And Caroline's committed to doing that. We had a long discussion about it at the Glasgow IGIB, and I had to confess that, and I'm 6.5 years on the board at GGC, and I hadn't heard it either. But we will clear that matter up, and I don't want us to lose the sense of progression that is taking place here, and this tidying up is too weak a word for what we're doing here, but we're trying to bring a focus in particular, of course, for children and young adolescents. Jacqueline, your hand was up and then back down.
Yeah, thanks, John. Yeah, most of my questions have been covered. I was agreeing with Mags, and it was just about the good practice that is in Renfrewshire, that obviously everyone's made a commitment to keep collaborating and working together, and it seems that that's been happening already anyway. So yeah, thank you.
Okay, thanks, Jacqueline. Are we okay about noting on item 2 in our paper, noting the contents in Appendix 1, and also noting that an update will be brought back to the March meeting?
Agreed.
Okay, thank you very much. we move on to the Chief Officer's report. Christine?
Yeah, thanks, John. So as always, I think the IJB will be familiar with this layout in terms of it's an update on key developments and activity since we last met in November, and any kind of policy developments. So I'm not planning to go through this paper because it has got a lot of information in it, but I'm happy to take any questions on it. I think what I would like to say is that we are continuing to work under significant pressure and demand. All of our services has seen an increase in demand. Everybody knows, because it's been well rehearsed here, about the challenges across health and social care around increased demand and difficulties in recruitment and retention. So we are no different within Renfrewshire. That I would like to say that the team have absolutely worked above and beyond over the last couple of months, which has been a really testing time. Winter normally is, but this year I think we've probably been under more pressure than ever before. So I just wanted to flag that. Also around the uncertainty that we're still working under in terms of our financial position, and Sarah will take us through that, and Karen will take us through some of the winter pressures and what we're doing to mitigate that later in the meeting. So just to say, if anybody has any questions about any part of the Chief Officer report, happy to take any questions, but we are covering quite a lot of it later in the meeting.
Okay, with that proviso, given that the senior management team are going to speak later on in the agenda, are there any questions to Christine? Okay. Whoop, Ian?
Okay, thanks very much. Very interesting report and a fairly honest report, I think, particularly in terms of the budget. You know, we're hurtling towards February, and we don't seem to know what's going on in terms of finances. I know things are difficult for everybody at all levels of government, but you know, the uncertainty is not great. I think Christian will not be surprised when I mention my concerns over doctor practices at the moment. The council unanimously agreed a motion last month at the full council meeting, expressing our concern how difficult it is for individuals to get appointments at their doctors, which is a real concern. I moved the motion and I spoke to it. And basically my concern was particularly for people who have got small issues. How big does that issue become when they don't get to see a doctor? When people go and very often see doctors can pick up and other things that, you know, us mere mortals wouldn't notice. So I'm really concerned, and people are just being put off and just forgetting about things, and it might end up coming back to haunt them in 2 or 3 months, 6 months time or whatever. In my own practice, you know, I never get a text from my own practice in my life, but it seems to be every other day. Don't bother contacting us because there's nobody here, there's no doctors, we can't see you. If it's an emergency, contact so and so. I know things change, technology changes and all the rest of it. I get that, I understand that. But it's a really worrying concern that the most basic of primary care, if that's the right word, if you know we can't get that right, and it worries me about other things. And I know the staff are, my God, they're really working hard. And last night on the news, I think it was a day last week when there was more deaths in one day than had ever been during any particular day in the pandemic, which is quite frightening. So that's, Christine knows I've been in regular contact with Christine over this particular issue, but I think this is the right place to raise our concerns, because if I open my door and I walk down the street, that's what people are saying to me.
Okay, thanks, Ian. Christine, do you want to field that one?
Yeah, so thanks very much, Ian, and we have been in regular dialogue about some of the concerns What I think probably would be best is the person closest to our practices across Renfrewshire is our clinical director, Stuart, who's here, who can give you a bit of an update on the position within Renfrewshire, and we absolutely are under pressure within Renfrewshire. So Stuart will give us a bit more detail, a bit more meat to the bone there.
Stuart, can you cut through some of the hyperbole there and give us an update?
Yeah, so I suppose the first thing to say is I completely recognise there will be people who will have difficulty getting access to their GP in the way they would have done prior to the pandemic. I completely accept that, but I would also, remind colleagues that the same is true for outpatients. People are waiting longer in A&E on trolleys for outpatient appointments. We have a situation that we've never had in the NHS, and that is going to take a long time for us to get on top of, despite everybody's best efforts. So I think the issues they're perhaps not as visible in primary care. I think people are well aware of what the challenges that our acute colleagues are facing, and the pressure around backlogs that they have, mainly because that is there are statutory recording responsibilities and reporting responsibilities around timeframes and waiting lists. We have a hugely challenging landscape in general practice in Renfrewshire that is driven mainly by recruitment issues of clinicians, but it's also becoming challenging for practices to recruit administrative staff, which affects registrations and processes around paperwork, which is a huge kind of burden as well. It's fair to say we have probably more of a challenge than other areas, other HSCPs at the moment. That's evidenced by the fact we've got more practices operating with list closures. A practice requests a list closure when they are basically at the point they simply can't manage any more patients, and that they need to focus on the patients they've currently got registered. That is generally agreed by the health board and via the HSCP. So that isn't something that we would have kind of an ability to prevent in most cases without entering a dispute with practices, which is clearly not a position you want to get into at the moment. In terms of access, all patients should have access for urgent issues, and that is our message to primary care at the moment, is you need to prioritise unscheduled care, emergencies and issues that people feel are urgent for kind of this day, this week. That inevitably has an impact on chronic disease management, and it is absolutely the case that things like chronic disease health checks and reviews may be delayed or may be taking longer than they would have done previously. That was similar during the COVID pandemic, and again, that is completely in line with what's happening with colleagues in acute in terms of scheduled care being significantly impacted at present. I completely agree with what Councillor McMullen says around people deteriorating, waiting for access to care. But again, I think primary care are dealing with the impact of people on long outpatient waiting lists who will be becoming more unwell and will be seeking assistance and support. And those people come back to primary care multiple times during the period of time they're waiting for scheduled care. And this in turn has an impact on people who are kind of entering a pathway of needing help earlier on in their illness. There isn't an easy solution to any of this, and we are working hard through the primary care improvement plan and the teams we've got in place. So practices have access to pharmacotherapy teams. They have, in a number of cases, physiotherapists in practice. They have link workers who are trying to help people who have got, particularly at the moment, issues around financial stresses or social stresses, housing issues, all of these concerns that will be coming into primary care as well. And we'll be finishing the launch of our treatment room. So every practice will have access to treatment rooms for patients who need dressings, injections, etc. That will be provided by the HSCP in locations around the local authority area. And that again is aiming to take some pressure off primary care nurses who deliver a lot of the chronic disease management for patients locally. In terms of escalation, there is a board-wide escalation plan, and that is agreed across the board area that practices that are struggling can move into that escalation where they would again be prioritising unscheduled care where possible. Additionally, we've had a practice close in the past 12 months in Paisley. That was due to the inability to recruit and find staff to place into that practice. Those patients have obviously transferred to other practices. That puts additional strain on practices that were already in a period of challenge. So that's, I guess that's the context, and kind of it's not saying that is where we want to be, but I think the message from me is certainly to my patients when I see them in practice and they say to me, it's taken me a long time to get an appointment, I haven't seen you for a while. that is not where any of us want to be. And I think the acknowledgement has to be, yes, we're not delivering the care we would like to be delivering, or we were able to deliver prior to the pandemic, but we are focusing on the places of most need and trying to deliver care, high quality care, the best we possibly can in the situations that we have, and also trying to retain the staff we've got, because one of the biggest issues we have now is that the moral injury for anybody working in the health service at the moment is significant, that none of us are delivering the care we want to deliver, and are obviously on the receiving end of understandable frustration from our patients and members of the public. We're desperately trying to retain staff who are actually opting to either leave or to take early retirement, or to move into a much more part-time way of working, simply because they can't cope with full-time work as things stand. So I guess that's the context in terms of what we're doing. We've got all the PCIP staff, we've got all of the services wrapped around general practice. I have consistent and frequent dialogue with all 28 practices regularly. But we're looking to support recruitment. So if you look on the internet, you'll see me trying to put myself forward as an example of seeking recruitment from out with Scotland to get GPs to come into Scotland, and talking about my personal experience. We've been engaged with the government around highly skilled worker visa programs. So we've supported the practices to register for visas so that they can recruit international medical graduates, of whom there are many training in Scotland, who need a visa to stay as a GP in Scotland. And we've also working with the local trainees to try and have a jobs fair, which will be coming up again in May, where we'll be trying to match trainee GPs coming at the end of their training to keep them in Renfrewshire, or tempt them to Renfrewshire from other parts of Scotland. So, we're doing everything we possibly can to improve the situation. If there are specific cases, obviously we're always keen to look into those, and we will pick those up with the practices. We'd encourage patients to raise concerns with the practice managers of their specific practices if there are concerns. But I absolutely won't. You won't expect me to say everybody who wants to see a GP for any reason at any time is going to be able to do so, because we're just not in that situation at the moment. However, absolutely, people who have an urgent problem and feel they need to see a GP or another clinician, because it isn't all about GPs, it's about advanced nurse practitioners, physios, the multidisciplinary team, and beyond that, they should be able to access support and advice during the kind of Monday to Friday 8 till 6 hours that their GP is open. So we'd be really keen to kind of have those examples shared if that is a concern. But the reality is, I think with acute colleagues, we're not in a situation where we're performing to the standards that we would have had pre-pandemic, but that is across the whole health service. So it's really about focusing the care on the people who need it most, and at the same time trying to boost our capacity and resilience. Sorry, that was a slightly long response.
Councillor McMillan, Ian, you want to bring this up, as do other elected members too, because it'll be in your mailbag all the time, and this is the place to bring it, and you've done that. Stuart, thank you for a very full response to this. This is a hard shift for you, these questions and so on, because there aren't any easy answers. But you've responded to that very genuinely and very fully, and the meeting thanks you for that.
Thanks very much, Stuart.
Jacqueline, Councillor Cameron.
It's on the same topic, John. It was just to caveat Ian's statement about the motion being unanimous. It was because, as you say, Stuart, there's no point in us saying that people aren't having difficulties in accessing, and for good reasons. It's just a different way of working. But I just wanted to say that I don't know if you were on the call, but there was certainly a lot of support for GPs, and certainly myself and Jennifer and Ian and other elected members, were wanted to make sure that came across as well, because I'm very concerned, as you say, about the morale of GPs. Talking to people who are GPs and friends, and I know that some of them are thinking of leaving GP practice, because the GP bashing has become a sport. It's become a social media sport. In fact, Ian will know that in one of our Johnston sites, a particular GP was actually being named, and there was a huge tirade about this person. I thought it was shocking. And one gentleman came on and said that she had phoned him at 9 o'clock at night you know, after a 12-hour shift and said, I'm sorry, I didn't get back to you sooner. So this is the pressures, and this is the circumstances that GPs are under. And I just wanted to deflect to you that we're conscious of that, and I think that the narrative really needs to change from the public. I know that they're frustrated, and I know that things are different, but you know, I certainly have never had any problems accessing my GP, nor has my mum, who's not been very well the past year or so. So anyway, that was all just a wee bit of a morale boost for our GPs.
Well, thank you, Jacqueline, and I'm sure Stuart would say through me, thank you. His shoulders are pretty round at the moment because of the weight of this, and I wouldn't like to be representing all the practices in our area, and it's obvious that Stuart does it with great concern, and he's not at all laid back about the matter, but it's a hard shift that he has in trying to answer and field these questions. But thank you very much. Are we ready to note Christine's report? Okay, thank you very much. Thank you. We now move to another hard shift, which is to Sarah Levers, in terms of the finances, which everyone is concerned about. Sarah.
Good morning, everyone. So as usual, I'm not going to read through the entire report, but I will highlight some areas, not as well, they are of concern, but just to keep members updated with where we are with things. And you'll all appreciate things are moving in the wrong direction financially. You know, everybody will be more than aware of that from the Scottish budget announcement and from local and national news. So you'll be more than aware of the impact of inflation and cost of living on everything that we do. So firstly, in the first section in 1.4, we still, I've highlighted there's still a delay in some of our ring-fenced allocations. So we're at the end of January and there are a number we still don't have for 22-23, and that includes the Action 15 monies. And I'm in regular dialogue with the government, chasing them up on this. So we're hoping that we will get these allocations shortly, but be aware that I am constantly on the phone or in Teams meeting when I raise this, because it is a concern to me that there's such a delay in receiving these monies. So if you move to section 3, I've highlighted that the projected year-end position is an underspend of 919,000, and members will remember that in November we agreed that we would use some of the in-year underspend in the health budget to fund the shortfall in the PCIP project monies. So that has been accounted for in the projected year-end position. So just to refresh people that is the position. So in section 3.3, I've slightly changed the way this is shown because I think it probably is easier for members to read if it's shown in a table. There's less narrative and it highlights the points more clearly. So you'll see very, very clearly that we do have an in-year underspend on employee costs, and that reflects part of what Stuart was saying earlier about the real difficulties we have in recruiting, and that's across all jobs right the way through all of our services, from admin to finance to GPs to absolutely everything. We are constantly battling our way to try and recruit people and encourage people to come and work in the sector. There's also a large overspend in the care at home service, and that really does reflect the Renfrewshire's position in terms of delayed discharges. They don't come without an additional cost, but we are performing very, very well, and Christine and others can probably provide more details on that. But it does come at a cost to the budget, which we're managing because we have vacancies at the moment. So that's the main areas I'd like to highlight in that section. And then if you turn to section 4.10, there's an illustration here about prescribing, because I think it's really important to members to understand the impact of prescribing on our budget. It's a very high risk budget for us. In the past couple of years, because of COVID, our volumes were down, so we were managing the prescribing budget pretty well. However, as you'll see in the illustration in 4.10, you can see how the actual cost per item has moved significantly throughout the current financial year. And actually, at the time of this report, it was £10.78, because prescribing is always 2 months behind because of the time it takes to get prescriptions through the system. So it was 1078 when the report was written, but it's actually moved to 11 as at November, and I think it's probably gone slightly higher. So that impact on our budget starts to become quite significant, as well as the increase of volumes. And you'll see what that actually means, and I've done an illustration below of the top 10 price increases over that period, which is quite eye-watering when you look at something that started off in April at £1.50 for 10 milligram tablets and moved to £57.57. So we have no choice. We have to actually give these medicines to people. They need them. They've been prescribed for them, but we have to manage that budget as well. So it is moving in the wrong direction. And I'm hopeful that at the year that we will manage this within the current financial year. However, I don't know what the current position is because we're 2 months behind, but I suspect it is moving significantly. But I'm confident we'll manage it in year. It's the impact of that in 23-24 that I think members need to be really aware of, because that's going to cause us real problems, and the need for us to manage that going forward will be very difficult. So that's very much on the radar. I wanted to bring that to everybody's attention today. And also just in section 5, just to remind members that the reserves in relation to COVID monies will shortly be returned to the Scottish Government. And for us, that's about 13.4 million that will be returned, and that will be done within the next few weeks through an invoice raised via the Health Board to remove that from the reserves. So that's pretty much everything I have to say on the report today, but I'm happy to take any questions. But actually, I will also add that we don't know yet what the budget allocation to us is this year, so we're awaiting clarification of that, specifically our share of the 100 million, and that's not yet been agreed by COSLA how that will be allocated. So as soon as we know that, it will be coming to the March budget report, but also I'm hopeful that I'll have more detail for our development session on the 17th of February, where I can talk about all of the pressures within all of the budgets and how we'll propose to manage them for next year. But I think it'll be no news to everybody. This will be a very, very difficult budget for us to set in 23-24. So just to sort of warm members up that, you know, things are going to be very difficult for us and difficult decisions will need to be made. So that's all I've got to say today. And I'm sorry it's not more positive, but that's the position that we find ourselves in at the moment.
Thank you, Sarah. Jacqueline and Ian have questions. Jacqueline, please.
Yeah, it was just about prescribing. Sarah, I was really shocked when I saw those prices, I have to say. And I was doing a wee bit of research because I wasn't sure who regulates pharmaceuticals. So it's the MHRA, but that's about standards and from what I gather. But what about prices? Does anybody regulate prices? Is there anyone who would say, no, we can't do that? It's you know, you need to cap it.
No, we're absolutely, and Stuart could probably answer this as well. We're absolutely the behest of the suppliers, and obviously, as you know, it's supply and demand. And for example, the impact of China at the moment on the cost of paracetamol because of the number of COVID patients that they've got is having an impact on the cost of paracetamol. The fluctuation in the price of the dollar, all of that has a huge impact. And usually we have maybe 15, 20 drugs that are on short supply and the costs are going higher and higher. But currently it's in the hundreds. So the impact is absolutely huge on us. I don't know if Stuart wants to add something to that.
Yeah, can I bring Stuart in, please?
Yeah, I mean, just to agree with what Sarah said, there isn't any mechanism to manage the price. It's the international markets, unfortunately, and as Sarah said, supply and demand. I think the other thing to mention is that there has always been, and there continues to be, work in primary care that GPs. The central prescribing team and the board have multiple different tools that are deployed in general practice to prompt you when you are prescribing to try and alternate or swap anything to you know, if there's a very expensive medication, if there is a suitable alternative medication that is just as good, they will be pushing prescribers and nudging people to prescribe things that are better value. But I think it's fair to say we're sort of at the really difficult end of the wedge now with some of these, and so aripiprazole, which was on there, which Shilpa will I'm sure agree is, you know, it's an antipsychotic medication for people who've got generally severe mental illness, and that isn't something you can easily just say let's take people off that and swap to something else, and it wouldn't be appropriate to do so just because the cost has changed. So there is a real there's a real difficulty in terms of how much of this we can control. There is a prescribing summit next week that has been organised by the board as well, and we'll be attending that. But again, it's another pressure in primary care, because we then turn around to GPs and say, can you do an audit and look through all of your patients on drug A, B and C, because these are really expensive, and then try and contact these patients and potentially see if you can swap them onto something which is just as good for them, but it needs a conversation, it needs a discussion. Often people don't like the idea of changing medication. So there's a whole range of additional pressures that puts when trying to mitigate the impact. And I think that, you know, again, there's a limit to how much of this we can actually mitigate, because where it is about international cost price, it's going to be quite challenging.
Thanks, Stuart. It's an unenviable conversation for a GP to have with a person who feels that the tablet that they're on, they're stable, and you're asking them to take a chance, well, in their terms. Okay, next is Ian McMillan.
Thanks very much. Sorry for dropping off here for a couple of minutes. I've got a 9-year-old granddaughter in the house who's off school because of the strike, so I'm having to look after her as well. And she's desperate to make a latte, and I'm not allowing her to do it herself. Anyway, I'll just go back to my previous point. You know, here we are again, February nearly, and we don't know the budgets. And I'm sure Sarah and her team have got lots of other things to do rather than chase up the Scottish Government. I just think it's ridiculous at this time, a few weeks before the new financial year, we don't know what's happening. So I'll reiterate that point again. I was totally flabbergasted when I read about the prices of the drugs. I drew a report to my Labour group about what's going on in the IJB, and I don't think they actually believe me. Some of the prices are absolutely incredible, and I think that's certainly something that we need to look at, that we're depending on the world market. Is it something that we could do here more ourselves in the UK and try and have a wee bit more control over the prices? I know they're absolutely unbelievable. I suppose that the main point I want to make is about this money that's going back. Now, everything I hear, every council report, every health report I read has got on it the impact of the pandemic. Now, I know the numbers are going down in terms of COVID. I think for the first time in a long time, I don't actually know anybody that's got COVID. And I'm not saying it's disappeared, and I know that people in the hospitals will tell you different. I know that, but we're still suffering as a result of the pandemic. You know, children's attainment is going down, for example, and various other things. Doctors' surgeries are struggling because of the impact of the pandemic. But yet here we are, the Scottish Government pulling back every penny. Now, you know, I'm not entirely sure. I'm not a high-level politician, and I know there's a COSLA meeting going on at the moment, and I was at a meeting last night where they discussed these reserves. I just feel it's unusual that we're just saying, right, okay, there's £13 million of reserves, we'll just hand it back. That's fine. You gave it in the first place. Pandemic's virtually over. There you are. The pandemic's not over. We're still struggling with the impact on it on a day-to-day basis in the health service and in the council. Surely there should be people sitting down saying, well, see that 13.4 million? Yeah, some of it can go back, but we need X amount to make sure that services are still provided for our local people. You know, we desperately need the cash, but here we are just giving it back. And I know the Scottish Government will probably have good use for that money. I know it doesn't disappear into somebody's back pocket. I know that, and it will be used for in other directions or other purposes. I know that, but it just seems galling to hand back this money when it's desperately needed here in the communities here in Renfrewshire. Thank you.
Sarah, can you give the meeting a feel for how involved you are with other chief officers and with the Scottish Government and so on, and give the sense of what I suppose is not unreasonable for people in the meeting to say, why don't we just go back and tell them they're not getting the money, kind of thing. Can you give us a sense of just how this process works?
Yeah, so the money that we got, the COVID monies, was specifically for COVID services, and the majority of that for us was provider sustainability payments. So those ceased not that much, a couple of months ago. So we no longer have provided sustainability payments to make, and we've also pulled back the majority of our COVID services, and that includes like the amount of PPE you need, etc. So our costs have hugely reduced, and you'll see that in the report that actually we actually haven't spent that much this year. So the money is going back to fund other COVID services still being held in the system, and that's like test and protect and vaccination costs. So the money isn't going back to anything else other than COVID, and then it will be redistributed by the Scottish Government to, some will be board services that are managed, and that will be things like the vaccination programme, etc. So that is the position, and I am part of the CFO team that does meet with Scottish Government on a regular basis to discuss things like this, and that includes things like the legality of it and the technical way that we actually would return the money. So I have been part of those discussions. So I think that's all I can really say about it at this moment. And you'll have seen the letters, because I included them, from Richard McCallum about the COVID monies earlier on.
And we can't use it for any other purpose.
No,
Sarah.
we can't. We cannot.
Thank you. Margaret Kerr.
Thanks, John. Thanks, Sarah. Sorry, my face is frozen on screen, but I am still here and moving. I guess my question, Sarah, is not in the detail of the paper, but I guess we're at the end of January. We will have to agree and approve the budget at the end of March. And you rightly said in your overview that difficult decisions will have to be made. So I suppose it's really just a question about how, as an IGB, we're going to be in a position within the next 2 months to have the information and be in a position to make appropriate decisions that are going to be difficult decisions to agree a balanced budget.
So that's the development session. We'll start going through all of that detail, Mags, on the 17th of February. So the plan is that we'll have quite a lot of detail will be coming there for members to ask questions, to ponder over, which decisions to make, which not, and then they will come to the IGB for the actual decisions to be made at the end of March, because I don't have the detail yet from the partner bodies. So until we have those budget offers, it's very difficult to know exactly where we are. So they will be teased out on the 17th of February. So I'm hopeful that you'll have more than enough information at that point to make these difficult decisions later on in March.
And just from my understanding, what is the position? Because that would leave one meeting, a full quoted meeting, for us to make that decision. What's the position if we can't agree a budget at that point? What does that mean for the IGB?
We then don't have a balanced budget, and we probably need to have, go into a recovery. We have to have a recovery plan. So that's in terms of the integration scheme. So the legality is that you have to set a budget by the 31st of March. And we have been in that position before, and we would need to carry it forward, but we would be in recovery mode. You have to have a financial.
And I suppose the reason I'm asking these questions is it feels like that is a strong possibility. I might be wrong there, but I think it's important that as a board we understand what the implications are and what that means practically for us and our responsibilities. And I guess that's why I'm raising these questions now, so that the members do understand the importance of what we're trying to achieve over the next 2 months.
Yeah, and I think it's important that members understand that we will absolutely have to use our general reserves next year to help us to set the budget, and that's non-recurring money, so you're just delaying inevitably difficult decisions to future years. But also we do have things like our earmark prescribing reserve, and it's likely that we'll need to use that as well. But I will come with that detail on the 17th of February, and it will also be in the budget paper on how we propose to manage the budget next year. But as you said, Mags, yes, it is very, very difficult decisions that will need to be made.
Thank you.
Thank you. I'm not keen as chair for us to delve into more detailed questions about the finances, because one, we don't have the answers, and two, we have this meeting set, development meeting set, when you'll have as much information as you can give us. But Sarah, but it's important that the meeting understands the importance of this, and that it's on our radar large, and we hope to resolve in some way between the development session and the actual March meeting when we set the budget itself. Anne, you've been waiting patiently.
Thanks, Chair. Well, I'll not ask any questions about the budget then, since Chair says we'll wait to the other meeting. That's fine. But one question then would be to Stuart in regards to the pharmacy part of it. My understanding is that we have the community pharmacies. Have we not got one community pharmacist linked to each GP, or multiple GPs to help us with that, looking at prescriptions and looking the cost of them? Is that correct?
Yeah, I'll come in there if that's okay, Chair.
Yes, please.
So I think we've got community pharmacists are obviously the pharmacists who work generally in community pharmacies, primarily dispensing medications, giving advice over the counter. We also slightly confusingly have HSCP clinical pharmacists, so primary care pharmacists who are employed by the HSCP, and that's part of the team I was talking about, kind of wrapped around general practice. So they have some of their time spent in a GP surgery with their allocated practice, but they also work in a hub. We've got now 3 hubs operating across Renfrewshire to provide 5-day-a-week cover. So basically they're doing work including quality improvement, but work that would have been done by GPs previously, to try and release some of the capacity of the GP team, and that's been fantastic. I think we wouldn't be in as good a situation as we were if it wasn't for those teams, and they will be doing some of that work around looking at swapping medications and cost-effective prescribing. The community pharmacies absolutely have a huge role and do lots of really positive work in supporting patients and practices, and increasingly have a bigger role kind of linked into the HSCP teams as well, but they are sort of slightly different.
Right, that's who I meant, Stuart. I meant the ones that work with the GPs, not the community as in out in the community pharmacy. My question then is, and it's just because my own GP is in Ayrshire and Arran, they have asked me to take 2 tablets instead of 1 tablet, because the 2 tablets are cheaper than the 1 tablet. Then and that seems a bit, I don't understand that, and that was my question. How can you have to take 2 tablets is cheaper than taking 1 tablet?
So that is the completely bizarre costings of some of the medications, that if you're on 10 milligrams of something, it may be cheap. The 5 milligram tablet may be a tenth of the price of the 10 milligram tablets. So instead of taking an expensive 10 milligram tablet, you'd be asked, can you take 2 5 milligram tablets, and you'll be saving the NHS £8 a month by doing that. So obviously it's a slight inconvenience for people to do that, but these, you're absolutely right, this is the sort of level of detail and the ask that both pharmacists and GPs are making of patients, and it's a way of everybody pulling together to try and save the NHS iteratively small amounts of money. But I think that is something we already do regularly, and it becomes more difficult, as Sarah's described, that if the price changes fluctuate month to month, what you don't want to do is say to someone, move on to 2 tablets this month. Oh, actually, it's now they're more expensive than the 1 was. You've got to swap back to 1 the next month, because there's a huge administrative burden, and it's frustrating for people as well. So it is complicated, basically. Right. Sorry.
Thanks, Stuart. I don't think it's, I mean, I think that we all need to play part in this, and if they had to change me to 1 tablet next month, I would take that 1 tablet rather than the 2 or 4, whatever the case. And I think we need to get that out to the general public, to say we need to be as flexible as possible to do this, so that we do have an NHS to see us through the next 20 years that I'm going to be living. After that, I'm not really caring, but as long as it's seen me through it. That's a joke. I'm only kidding at that part of it. Thanks, Stuart.
Okay, and as they say, keep taking the tablets. Sarah, did you want to come in and clarify?
Yeah, I just wanted to reassure people that actually Greater Glasgow and Clyde is actually in a better position than a lot of the other boards, because of the work that has been going on with the prescribing and pharmacy teams over the past few years. So our average cost per item is actually considerably lower than, for example, Lothian and the Borders, etc. So although we're in a pretty awful position, we're actually, it shows that the amount of work that we've done with Script Switch and the pharmacy teams, etc., has had a huge impact. However, what that does mean is that we don't really have anywhere to go now because we've already done all of that work. So it was just to let everybody know. And Anne's comment about changing drugs as well to having maybe 4 instead of 2. We thought that was a great idea. However, now the pharmacy companies are getting quite cute and have realised that. So that seems to be something that's disappearing as well. So it's just coming from all angles. But we're certainly very much the leaders in Scotland in terms of prescribing in Greater Glasgow and Clyde, just to reassure everyone.
Okay, thanks, Sarah. I don't see any more hands up. Are we ready to note the 3 bullet points here on item 2 in the face of the paper? Note the in-year position at the 30th of November 2022 and note the projected year-end position for this year 22-23 and note the current estimated financial assessment of the consequences of COVID-19 pandemic in this year to 22-23. Okay, thank you. We come to Francis and the performance management mid-year report 22-23. Francis.
Yeah, thanks, John. Yeah, as you say, this paper provides the mid-year performance. So that's the period from April to September 22. Similar to previous reports, we provide the full scorecard as an appendix, and in the cover report just pull out the main areas of improvement, areas of focus, and give a more detailed update on unscheduled care. So section 5, we've highlighted where we've seen improvements, and members will note that we're starting to see a payoff around CAMS and breastfeeding, some of the areas where we've previously updated you on improvement work that we've been undertaking. In section 6, we highlight areas of focus that we have improvement work ongoing. So areas such as speech and language therapy, absence management, which has been a real focus for the SMT, and also alcohol and drugs waiting times. And you'll know from the previous meeting, Laura talked about that and shared some of the work that we're doing about that on the back of the discussion at our last meeting. And then the final section, section 7, we give a more detailed update on unscheduled care. The only point I would note is that as this report just runs to September, it doesn't cover the winter period and the winter pressures at this point, although there is some positive news coming through with some of the figures that we've had through even into November, where we're still the highest performing local authority around standard delays in discharge. You know, we're consistently performing at a really high level, which is good news. And also one of the areas of focus around CHURAS, actually the more recent figures that we've had around that shows a marked improvement. So we're hopeful that while we expect the winter pressures to have an impact, we're also seeing improvements in a number of areas through this proactive work that we're undertaking. So very happy either for myself or the relevant head of service to pick up any questions you may have. Thanks.
Thanks, Francis. Are there any comments or questions on Francis' report? Don't see any hands up. Well, thanks again, Francis. These reports they've all got a lot of work behind them, and we thank those in the other areas for their dedication too. And I come to the recommendation on item 2 on the front page. We're recommended that we approve the performance management mid-year report 22-23 for Renfrewshire HSCP. Is that agreed? Thank you. And we come on now to the unscheduled care winter update, and it's Karen Byrne. Karen, you're there?
Yep, thank you, John. So this morning's report really builds on a previous report that went to the IJB in March 2022, and it highlighted the progress made in respect to unscheduled care delivery plan. This morning's report, however, it seeks to update members on the developments in respect to governance to unscheduled care and to highlight some progress in respect to the 3 key areas of high impact change which have been undertaken by the NHSGGC. And these 3 areas of high impact change really are to mitigate a number of the pressures which have been well rehearsed through the IJB and also to try and mitigate the challenges in respect to winter. Although I think we've all been made well aware of some of those pressures through the media and through previous reports, but it almost feels as if we didn't really actually get out of winter pressures even throughout the summer. It's felt as if we've just gone from one situation to another. In terms of the report, the new governance structure can be found on Appendix 2, so I won't go through that in any detail, but really just to pick out the most significant change is the implementation of the new Urgent Unscheduled Care Oversight Board. And that board really draws together all of the unscheduled care activity across GGC, and that ensures that there is links to both COVID-19 recovery tactical group and that there is oversight in respect to the Moving Forward Together programme board. And again, that's to make sure that all of the existing, I suppose, cluttered landscape around unscheduled care is coming together and is being driven forward through both of these governance groups. And it really does capture a very changing and dynamic landscape, because as we know, there's new challenges and new initiatives brought forward from the Scottish Government at a rapid pace, and all of these the new structures and new governance boards make sure that there's a home in respect to governance for all of the changes. With regards to the 3 high impact change areas that are highlighted within the report, the first area is around virtual capacity. And this change area was really designed to offer an alternative to face-to-face inpatient care. And the target of the work stream really is to reduce the number of patients self-presenting to ED, to increase the number of patients assessed and discharged through the use of the new Near Me consultation, and to increase the number of patients attending more clinically appropriate pathways and avoiding that unscheduled care that people coming to ED where there are far more appropriate pathways for those patients. To date, we've got 14 virtual pathways now live across GGC, and there is options to extend this even further. And again, what we know is that these new pathways are being well received. The second work stream is around the rapid assessment and discharge, and this work stream seeks to optimise flow across the system, utilising the discharge to assess policy and ongoing discharge without delay activity. We're still developing key performance information around both of these work streams to ensure that they're having a positive impact on some of the challenges. The final high impact change area is the community focused integrated care, where there's 3 key work streams. The first one is the community falls pathway, the second one is the hospital at home, and the final one is the home first response service, and that's led by ourselves within Renfrewshire. And I won't go into any detail about the work that's been undertaken by those 3 work streams because it's well reported this morning. It is contained within the report. What I will say is there is quite significant progress has been made across all 3 of these pathways, and there is ongoing work to continue to develop them and to upscale them at the appropriate time. As I said before, all of the work streams around unscheduled care are continuing to be monitored, and progress has been reported in through the new governance structure. So in terms of this morning's report, the board is really just asked to note the content, and I'll bring a further report probably in the summertime to capture any and all progress that's been made in respect to unscheduled care. But I'm happy to take any questions that anyone has.
Any questions? Fiona Milne. Fiona, you look cosy.
Good morning, Chair. I'm saving on the heating bills.
Good.
I'm only kidding, I'm just getting ready for work. Just in terms of the virtual pathways, I think that's super what you're doing. However, I think particularly the elderly and the disabled community maybe couldn't access those. But just to see how we go about reaching out to that vulnerable group of our community.
But for that vulnerable group, Fiona, they would always be those pathways that exist pre the virtual pathways. So for anybody who is finding difficulty, accessing Near Me or any of the virtual pathways, they still have the opportunity to go through their normal pathways. You've got your GP, all of those pathways still exist.
Thank you.
Okay. Margaret Kerr, Frozen.
Hi, thanks, Karen. It's a pretty straightforward question. It's in Appendix 2. If you look at that up at the top left, under the title, there's a line that says New Whole Systems Oversight Board. I'm just looking for clarity as to what that is, because it's not clear in the structure underneath. The rest, it's fairly obvious: rapid discharge, virtual pathways, but Whole Systems Oversight Board, I just wasn't clear. Okay. Is that the community piece?
It's a board that's actually chaired. It's across the community and the acute service. It's chaired by the Chief Operating Officer for NHSGGC, and the Vice Chair is the Chief Officer for for Glasgow City. So it's a joint board that sits across both the NHS and acute service.
Christine, do you want to say something about this one?
Yeah, it was just to say that board is co-chaired by William Edwards and Suzanne Miller, and what sits under that overview board is a number of subgroups. So one is discharge without delay, which I co-chair it with Jen Rogers. So what we're trying to do is we're trying to make sure that we are absolutely working across both systems. So we're working across acute and community as a whole system, and we think that will flush out some of the delays and some of the challenges that we have. So it was just to clarify that, John.
Yeah, thanks, Christine. And it's maybe just the way I'm just trying to understand, because I can see the one that's chaired by William and Suzanne, but it's just in the top left there is another line that says New Whole Systems Oversight Board. Is that one and the same thing? It's just because it sits underneath the heading of Urgent and Unscheduled Care Oversight Board. I'm just trying to clarify, are there two separate things, or is that just a different term for the same thing?
It's one and the same thing, Margaret. It might be the way Max, it might be the way it's actually written. So I can go back and get clarity for that for you. But
yeah, it's just so that I understand whether we're talking about one or two different things. So it's just a very minor point. That'd be helpful for me. Thank you.
Yeah.
Okay, Jacqueline, Cameron.
Thanks, John. Yeah, it's a really good report and lots of good work going on. But it was a very specific question, Karen. It was about the interim beds in care facilities and care homes. I just wondered if, for people who are waiting to go home with a care package, if there's a reluctance to go into a care home. I know that certainly for older people, sometimes it's quite, anxiety inducing to be put in a care home where they may think, well, will I end up staying here?
Absolutely. And that's some of the worries, Jacqueline, that we have. So we work really closely with families and with the person themselves to say, you know, that this would not result in you absolutely staying within a care home. Absolutely not. It's until we get a package of support. We don't have an awful lot of people where interim beds, where we require interim beds. You know, it's for a very small minority, because in terms of our care at home, we've been really receptive in turning packages around. So the main use of our interim beds really is for people where we're waiting on their permanent care home and where they don't have capacity. So the use for people in the community really is exceptionally limited, and we make sure that we review it on a constant basis. And really what our expectation is there is a turnaround within 6 weeks. So somebody wouldn't be any longer than 6 weeks within a care home, but we would never do that against the person's wishes. So it's always with the consent of the person. And again, it's like I said, in terms of our care at home packages, we've got a very responsive service who really get packages of care in place exceptionally quickly.
Thanks, Karen. Thank you.
Okay. Jacqueline, Christine, you're coming in to clarify.
Yeah, just briefly. So as Karen said, that, you know, in terms of interim beds, sometimes people will know that you, if you're in hospital and the decision has made that it's likely that you now need long-term residential care, families and the patient, apologies, families and the patient then get to choose their care home. And sometimes that chosen care home doesn't have a vacancy immediately. Now, sometimes it can only be a matter of days or maybe the following week. But the challenge for us there is sometimes we will then offer an interim placement, and the families are reluctant to take that up, Jacqueline, in terms of, because they want to avoid another move for their loved one. So we completely understand that, and we really do try and work with the families. The challenge for us, as you know, is that the pressure is on within hospitals. So we are working, it's you know, Karen's team has got a tricky job in terms of working closely with the family, working with colleagues at acute, also working with our independent care homes and our own care homes to make sure that we can, you know, at times particularly our independent care homes are staggering admissions for us, and that's absolutely because of staffing issues at their end, and they want to have safe admissions. But all of that and juggling all of that is a challenge, but Karen's team are well versed in that, and I think we've got a good reputation in Renfrewshire to talking to families and you know, hearing what their concerns are and trying to come up with the best you know, package that will meet their loved ones' needs and alleviate some of the stress and concern that they've got around that.
Thanks, Christine, for clarifying that. I don't see any more hands up. The report, Karen is asking us to note the content of the report and to note too that a further update we brought in the summertime, updating us on the work that's being done in health and social care. Okay, the date of the next meeting will be 10 AM on the 31st of March 2023, and also just remind you that the development session is in the Lyndhurst Hotel on the 17th of February, and there's some significant things to be discussed there, as we've explored in the meeting here, particularly around finance and getting update there, which will be very important for the ongoing performance of the Renfrewshire IJB. So I don't think there's anything else, Christine? No? Okay, I just thank all of you for your attendance and for coming today, and look forward to seeing you at the Lyndhurst Hotel when I understand there might be biscuits.
Let's hope so.
Thanks,
Okay.
John. Bye.
Okay, right, thanks very much.
Thanks.
Thank you.
Bye.
Bye. Bye.
Thank you.
Thank you. Bye.